Good day everyone. Today I am going to talk about acute kidney injury after pediatric cardiac surgery. I am Dr. Sadbir Kaur and my lecture will deal only about AKI after pediatric cardiac surgery, all its post-operative challenges and management. There is no hardcore definition of AKI, but it is abrupt, that is within hours, decrease in renal function which encompasses both injury and impairment, that is loss of structural and loss of functional nature in kidneys. If we talk about pediatric patients after cardiac surgery, the estimated incidence is huge, that is around 30 to 52% and even higher incidence of up to 60% in neonates, with a high mortality of about 5.2 to 12%. Acute kidney injury has a direct relationship with increased ICU stay, more mechanical ventilation hours and post-operative morbidity. Hence, AKI is something which should be early identified. Patients at risk should be assessed first and it should be mitigated at the right time. Now, to classify AKI, there are many clinical criteria. The most commonly used three clinical criteria are P-RIFLE, that is pediatric risk, injury, failure, loss and end-stage renal disease. AKIN, that is acute kidney injury network. But the most widely used and validated amongst all of these is KDIGO guidelines, which is kidney disease improving global outcomes. Now, all these criteria are very practical and they are based on serum creatinine changes and urine output. Until a new practical gold standard is validated, serum creatinine is a mainstay in assessment of renal function. Talking about KDIGO guideline, the study which I have shown on the right of the slide, that is validation of KDIGO acute kidney injury criteria, was a huge study in about 2000 pediatric critical care population, and it validated this criteria hugely. Now, this criteria defines AKI in terms of three stages. First stage is stage 1, that is when serum creatinine rises by 1.5 to 1.9 times baseline, and or you can say when creatinine increases by 0.3 milligram per deciliter and the urine output decreases less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 is more severe, that is 2 to 2.9 times baseline serum creatinine and less than 0.5 ml per kg per hour for more than 12 hours. And the third stage is almost renal failure stage, and that is 3 times baseline or increase in serum creatinine to more than 4 milligram per deciliter. In this, the urine output drops considerably to less than 0.3 ml per kg per hour for more than 24 hours or anuria for more than 12 hours. Now, there is a special neonatal AKI KDIGO classification which is almost similar but has some changes in it. First of all, there is a stage 0 in which there is no change in serum creatinine or rise of less than 0.3 mg per deciliter, and the urine output is also more than 0.5 ml per kg per hour. This stage was created in this classification so that the neonate at risk can be already assessed and included in the AKI staging. And the second difference is that the reference creatinine, the baseline creatinine, does not have a range. It is the lowest previous serum creatinine value. Why is that? Because in the first few days, the neonate reflects the maternal creatinine and it is on the higher side. And thirdly, on the stage 3, the reference creatinine or serum creatinine is more than 2.5 mg per deciliter, and that is a huge change for a neonate, and it represents less than 10 ml per minute per 1.73 meter cube of creatinine clearance. KDIGO is globally recognized, and our setup in pediatric cardiac recovery ICU KDIGO criteria is used. It is validated, and how do we use this? For example, we apply an equation called Shor's equation, in which we have a constant k which is different for different age groups of pediatric population. It is 0.33 for preterm neonates less than 1 year old, 0.45 in full term infants less than 1 year old, and 0.55 in the rest of the population. And the equation is this constant into height in centimeters divided by serum creatinine. So we take this formula and we have serum creatinine being measured every 24 hours. So we take out the creatinine clearance, and if that clearance is less than 40, then we define that the patient is in AKI. But it is not only just numbers. The clinical situation of the patient is also taken in consideration, because serum creatinine and urine output are many times confounded. So you have to look at the patient and see how the patient is doing clinically. Now, serum creatinine and urine output are the most practical markers that we have, but they can confuse a physician, because serum creat is a delayed marker. It reflects increase when 25 to 50% renal function is lost. Secondly, it varies with muscle mass, gender, hydration state and age. Serum creatinine is in the first few days of a neonate reflects that of maternal values and not infant's renal function. Overall GFR in preterm and term infants is very low, and there is very wide distribution in serum creat value. After the initiation of dialysis, creatinine is easily dialyzed. So all these things can give you different serum creatinine values. So clinical assessment is of great importance. Urine output is an earlier marker, because as the patient comes to us in the ICU, we get the serum creatinine value of a baseline, that is before pre-op value, and we get it the next day. But urine output is right there in front of us. There should be good urine output measurement hourly, and it is the earliest marker we have of falling GFR, and that's how we assess whether the patient is going into AKI or not. But even urine output is confounded by intra-op use of diuretics and volume status and use of fluids. That is why we have these two markers, but we need more biomarkers for an earlier assessment of AKI, so that we can put the children in the right section of the treatment, that whether they need renal replacement therapy earlier or not. Such early biomarkers are there, and some of the important ones I am telling you. First is neutrophil gelatinase associated lipocalin. It is in serum as well as urine. It is secreted by the distal renal tubules in nephrotoxic and ischemic AKI. So many studies have been done about the NGAL, and it has been found that in pediatric patients, it increases about 10 folds as early as 2 to 6 hours post CPV. And if we talk about the second marker, this marker is statin C, which is a superior biomarker in the estimation of GFR, and unlike serum creatinine, it is unaffected by gender or muscle mass. And Zappitelli M. et al. In 2011 conducted a huge study in which cystatin C was seen to rise as early as 6 hours after renal injury during CPB, and it was a strong predictor of AKI. The third markers is a dual marker, that is IGFB7, that is insulin-like growth factor binding protein 7 and tissue inhibitor of metalloproteinases, TIMP2. These are markers of cell cycle arrest, and they also show significant high values as early as 4 hours after a cardiac procedure, and is also US FDA approved. So all these markers unfortunately are of very high cost and not economical, and hence are not available here in our setup. But combining these markers like cystatin C and NGAL together are proven to be very strong in predicting AKI severity. Now this is a very important slide that I have, which tells us that which pediatric patients should be put under the risk of AKI. As soon as a patient comes to us, if we know all these risk factors, we can already predict whether the patient is likely to go into AKI or not, and we can start the treatment as soon as possible. I have divided this in non-modifiable and potentially modifiable categories. Non-modifiable is a younger age group, that is less than 12 months. Even in that, the neonatal age group is of most risk. Then preterm neonates, single ventricle, higher RACS category, that is risk adjustment for congenital heart surgery, that is surgeries like double switch or TAPVC, obstructed ones, all these comes in a higher risk category. Small or single kidney, preoperative pulmonary hypertension or crisis, preoperative aminoglycoside exposure is also shown to increase the risk of AKI. Any perioperative prolonged ventilation, if the patient is in low cardiac output state before the surgery, less weight for age patient, cyanotic lesions, and higher baseline serum creatinine values. All these are pre-op factors which can put the patient at risk after cardiac surgery, pediatric patient. Second category on my right is potentially modifiable, that is somewhat in our hands to prevent AKI. First is how is the CPB perfusion, second is the CPB time. If it is more than 120 minutes, it's said to be harmful for the kidneys. Third is perioperative fluid overload, that means to the last ml how much volume we are giving the patient on the OT table and immediately post-op, that is also very important. Perioperative anemia or hemoconcentration, that means patient should not lose a lot of blood, or the patient should not have hemoconcentration as well. Because there was a study by Paediatric in 2016 in which the patient which had baseline HB of more than 11 gram per deciliter, at POD1, if their HB was more than 3 gram per deciliter of their baseline value, they were also at risk for AKI. That means we should not give excess blood products to the patient. Fifth is increased vasopressor and inotropic support. Directly, it vasoconstricts the renal vessels and causes a risk factor. Positive fluid balance in the first 3 post-operative days is a direct link to a higher risk for AKI. So, it is a very important factor which we as intensivists can prevent. And seventh is sepsis. Now, modalities for preventing or managing AKI in the ICU. When the patient comes to us, the first thing which we can do is identify the child at risk. According to all these risk categories which I just spoke about, patients should be stratified for risk of AKI according to their susceptibilities and exposures. General post-op measures are first that you have to maintain cardiac output. This is very obvious that if the renal blood flow is good, there is less chances of ischemia and renal function loss. So, maintain optimal mean arterial pressure for age. Second is optimal vasopressor use. Don't give excess vasopressors, especially vasoconstrictors. If we see vasopressin versus NORAD, the studies indicate that vasopressin is superior in terms of renal circulation, and low dose dopamine, which right now even many people choose to use to lessen the risk of AKI, that is to safeguard kidney, is however not proven to be beneficial according to KDIGO guidelines. Then avoid hypovolemia and anemia. But the last thing which on this slide is the fluid balance, which I think is one of the most important things that we have to take care of, even in terms of AKI and also generally, because fluid overload is very crucial and detrimental for a pediatric patient. It puts the patient directly at risk for AKI. And fluid overload index of more than 10% in post-operative period, that is around more than 100 ml per kg per day, and during RRT, renal replacement therapy, is directly associated with cardiac surgery AKI and increase in 90-day mortality. This picture shows us that how fluid overload can cause AKI, how it can precipitate AKI in children. Fluid overload can cause increase in bowel wall edema, which leads to direct bacterial translocation and sepsis, which is detrimental. Secondly, it affects endothelial dysfunction, glycocalyx damage in the kidneys, which results in decreased intravascular volume. Stretching of the atria and blood vessels leads to ANP release, which leads to the same thing. Renal congestion, interstitial edema due to fluid overload can impair metabolite diffusion and compromise renal oxygenation, which in time decreases the renal perfusion. And very important is the increase in intra-abdominal pressure, because the fluid, if it collects in the peritoneal cavity, it can lead to microvascular flow and compromised the renal circulation. And further increase in intra-abdominal pressures can lead to decrease in cardiac output and rise in all the inflammatory cytokines, which affects the kidneys and can lead to AKI. So fluid overload is directly detrimental to pediatric patient in many ways and also causes AKI. We should maintain electrolyte balance, that is maintain normal levels of serum sodium and potassium. Avoid potassium containing solutions and don't give overzealous or overcorrect the potassium. Be very specific and very prompt in the correction of potassium. The fluid therapy should be goal directed and excess fluid should not be given post-operatively to the patients at risk. When you look at albumin versus crystalloid, the studies are controversial still right now, that which one is better or worse in case of patients at risk for AKI. But KDIGO guidelines suggest that first crystalloid should be used and colloids later for fluid resuscitation in such patients. If you look at the blood products, overzealous transfusion is strictly deleterious. It has been positively linked to AKI. But in this study, the table that I have shown here, FFP has the most positive link to AKI risk. So the number of FFPs that you give in the first day leads to, if you give it in a overzealous manner, can lead to a higher risk for AKI. Avoid hypothermia in such patients, because hypothermia leads to the vicious cycle of metabolic acidosis and renal ischemia. There is a concept of passive peritoneal drain, that is the surgeon inserts a peritoneal drain in the pediatric patients after the surgery is done before sending the patient to the ICU in the peritoneal cavity, so that the excess fluid can be drained out. And if we, as intensivists, if we want to start a renal replacement therapy in terms of peritoneal dialysis early on in the patient and prevent fluid overload, keep a negative balance, that can be started early on. And in this very good study by Kamal K. et al., the pediatric patients which received the passive peritoneal drain after cardiac surgery reached negative fluid balance earlier and used less diuretic in early postoperative period. So inserting a prophylactic PD before even the patient comes into the ICU is a very good idea to mitigate AKI at its earliest. Being watchful for oliguria is one of the main things that has to be done after the patient reaches the ICU. Oliguria is less than 1 ml per kg per hour of urine for more than 4 hours after procedure. Assess the patient for low cardiac output, and if the patient is losing blood or is hypovolumic, we must resuscitate accordingly and optimize. If the patient is negative in terms of furosemide responsiveness post 6 hours of CPB, that is considered to be an important predictor of AKI. So if the urine output drops in spite of a good MAP, you have optimized the MAP, and even the furosemide responsiveness is less, it is one of the factors which is a predictor of AKI. Patients at higher risk, that is a patient, for example, is a neonate with an open chest who has had a pulmonary crisis in the OT, had hemorrhagic shock, is in low output state, is already considered a patient who is at risk for AKI. So that patient should be put on peritoneal dialysis way earlier before assessing everything else, such as furosemide responsiveness. So all these things should be taken into account, and oliguria has to be watched out for. Nutritional requirements increase when the patient goes on renal replacement therapy. Good protein intake is around 0.6 to 1 gram per kg per day, and it can go up to 1.5 gram per kg per day in patient on RRT. And adequate caloric intake is very important in such patients, and always enteral route is preferred. In patients at risk for AKI or with high serum creatinine values who have sustained renal injury, we have to avoid nephrotoxic, antibiotics, sedatives and analgesics. And every day as we get serum creatinine of these patients, we must calculate creatinine clearance every day, and dose adjustments of these drugs which are on my right should be done regularly so that we don't give an overdose of such drugs. Talking about the renal replacement therapy options that we have in pediatric patients, we have intermittent hemodialysis, we have continuous renal replacement therapies such as continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, continuous veno-venous hemodiafiltration, slow continuous ultrafiltration, continuous arteriovenous hemofiltration, sustained low efficiency dialysis or SLED. But all these techniques impacts hemodynamics of the patient who is already in low cardiac output or already is having issues. This can lead to further problems because they need anticoagulation, they need large excess. There can be issues of bleeding, hypothermia, acid-base imbalances, thrombocytopenia. There can be altered immune response and clotting issues. So the best bet that we have is peritoneal dialysis. It is the most effective, the most cost effective and the most physiological way of doing renal replacement therapy and mitigating AKI in pediatric cardiac ICU after they come after the surgery. So peritoneal area is very large in pediatric patients. It is dynamic and dialysis happens there, and it is very physiological. It is less pro-inflammatory and it mitigates the post-CPB capillary leak syndrome. We can do large volume of ultrafiltration through the peritoneal drain with minimum hemodynamic or respiratory instabilities in pediatric patients. It needs minimum infrastructural support and is very cost effective. So overall, peritoneal dialysis is our mainstay in treating AKI. What is the ideal time to initiate peritoneal dialysis? There is no set protocol, it is up to the clinician. But when patients fall under this KDIGO AKI criteria with decreased clearance, you should start PD, and there is physical evidence of total fluid overload. That is more than 5% of fluid overload or pulmonary edema is seen on the X-ray. Patient is not breathing properly. There is a lot of swelling on the patient can be physically seen. We should start PD so that there is effective negative balance from the first day onwards. The patients which are at risk should be initiated PD without giving it much thought and waiting for the creatinine to rise. It can be started on the first day onwards as well. There is inadequate urine output of less than 1 ml per kg per hour or anuria, which is unresponsive to fluid challenge, and IV furosemide for at least few hours. Then we should start peritoneal dialysis. There is concomitant low cardiac output syndrome with refractory hyperkalemia and acid-base imbalances. Peritoneal dialysis is very important to be started early on in such patients. Low age group patients with complex congenital heart surgeries and other perioperative risk factors, even prophylactic PD can be started so that these patients before they develop AKI and go in that vicious cycle of metabolic acidosis, lactic acidosis, the peritoneal drainage can be started and the patient can be maintained in a negative balance, and even their cardiac output also improves if we start PD prophylactically. Now this was a study by Bojan et al. It was a retrospective cohort study of 146 neonates and infants after cardiac surgery, in which he compared early PD to late PD, that is early on PD on the first POD to late PD after on the second or third day. And what he saw was that in early PD there was a better 90-day survival as compared to the patients in which PD was commenced on the second day. So in the patients in which we can identify the risk factors, we should put them on prophylactic PD early on. Now how to start PD? The prescription for peritoneal dialysis can vary according to the clinical state of the patient. Length of the dialysis session is how the patient is doing clinically. That is, we ideally start in 1 hour interval, that is we start PD hourly. But if the patient has a lot of fluid overload, has issues such as very high metabolic acidosis or hyperkalemia, we can start it at half hourly intervals as well. If we talk about the composition of the disulate, we use here is 2.5% dextrose. So if we want to correct the fluid overload at a fast pace, then we can start with a higher concentration of dextrose as well. It clears out fluid even more. Third is the exchange volume. Initially the fill volume should be 10 to 20 ml per kg. Maximum you can go up to 30, but in small patients going to this volume can lead to respiratory or hemodynamic issues. So we start in our setup from 10 and we can go up to 20, not more than that, because the higher the fill volume, the greater the clearance, but it leads to other issues. Inflow, dwell and outflow time, ideally if we do it 1 hour, the inflow is 10, dwell is 30 to 40 minutes and outflow time, that is draining of the fluid out, is 20 minutes. Now shorter dwell time can be done if we want rapid fluid urea and potassium clearance. So a shorter dwell time will lead to a rapid clearance. If you want to correct hypernatremia, we can extend the dwell times. It clears sodium in a better way or lower the glucose concentration in the dialysis. Now when we are doing PD, we need to have ABGA 4th hourly so that we can monitor potassium, and the fluid balance should be calculated every 4 to 6 hours, and at 24 hours there should be a detailed calculation of fluid balance. Serum electrolytes, blood sugar, everything should be monitored very regularly, 4 to 6 hours hourly ideally, and blood urea and serum creatinine every 24 hours. When to hold PD? When the patient is clinically doing better, the patient is holding pressures, there is better urine output, better creatinine clearance, the serum creatinine has come down to normal levels, adequate negative balance is achieved. You should physically also see that in the patient. The swelling has decreased, the X-ray is clearer, there is good urine output, even post furosemide challenge, and there is no acid base or electrolyte disturbances anymore. Then we can hold PD and possibly wean off the patient. Talking about Lasix or furosemide, it is not an ideal drug or recommended to treat or prevent AKI. Furosemide challenge and response is however useful predictor of developing AKI, and it can be done once fluid status is optimized. As we can see in this picture which is there, after post-operative stabilization, index furosemide can be given after few hours, and if the patient retains a good urine output of 4 to 5 ml per hour, then okay. But if after index furosemide the urine output decreases to about 2 or even 1 ml per kg per hour after few hours, then that patient is at risk for AKI. So it is a good predictor in that sense. But if you look at furosemide versus peritoneal drain for achieving a negative fluid balance, in pediatric patients, the PD is proven to be much more superior with decreased ICU stay, duration of mechanical ventilation and decreased inotropic support. This was compared in a study by Kwiatkowski et al. And it was a very good study which proved that furosemide is inferior to peritoneal dialysis in achieving negative fluid balance. So I would like to just mention some pointers for discussion, that strict fluid input output monitoring is very much required for smaller patients, for pediatric patients. It should be started intraoperatively and carried on postoperatively till the end. Infusion based blood product administration is much more feasible and is much more beneficial for the patient, and overzealous blood products should not be given. AKI care bundle should be there for pediatric patients, and it should be different for different age groups of the pediatric patients. New biomarkers that we talked about like NGAL and Cystatin-C should be incorporated in our practice for a better prediction of AKI in such patients, which can be done. And there are many lacunae in research. We can do further research and determine all other risk factors which are there to determine and mitigate AKI in a much better way. Thank you everyone.